Hello friends, in the previous video we have discussed about the causes of peripheral nerve injuries, their classification, their degree of injury, their evaluation and the basic principles of management of peripheral nerve injuries we have discussed. In this video we are going to discuss about the specific nerve injuries. The first nerve is we are going to discuss about are the brachial plexus injuries. The brachial plexus is nothing but the plexus that is originating from the distal cervical as well as proximal thoracic nerves to supply the entire upper limb. So the root value for brachial plexus starts from C5 to T1. So basically these brachial plexus injuries are occurring due to high velocity motor vehicle accidents in the current standard. So whenever a person falls like this after a motor vehicle accident, the angle between the shoulder and the neck gets increased or stretched. So shoulder being pulled down and the neck being pushed away. In such cases, see it can cause avulsion of the upper roots. Okay, that is C5 and C6. Whereas when a patient is falling from height and he clings on to some branch or something, it will cause forceful hyperabduction. So hyperabduction will cause traction or avulsion injury of the lower roots, that is C8 and T1. So there are three common types of brachial plexus injuries. Number one is going to be avulsion. Avulsion is nothing but pulling forceful pulling or tearing. Next one, as the name dictates, stretching. And finally rupture is known as rapid knockoff. During pulling causes rupture. Now moving on to clinical features. So the upper root injuries or upper trunk injury C5 C6 is termed as Erb's paralysis. So what happens when Erb's paralysis occurs C5 C6? The muscles supplying C5 C6 will be paralyzed, like deltoids, biceps, brachialis and supinatus. So each of the muscles have become paralyzed, leading on to the deformity. So deltoid function is lost, so shoulder becomes internally rotated. Biceps gone, so elbow is extended. Biceps and brachialis. Supinator, so it cannot supinate, so forearm becomes pronate. So finally giving a, so this is called the internally rotated and elbow extension and forearm pronated look, that is called a policeman receiving tip. This deformity is called policeman receiving tip. What happens when the lower trunk gets injured? That is called C8T1 injury, that is called Klumpke's paralysis. Since T1 is also involved, there is a high chance of a sympathetic trunk getting injured. So when the sympathetic trunk gets injured, it causes Horner syndrome. You all must have heard about Horner syndrome. Horner syndrome is nothing but meiosis enophthalmos. Enophthalmos means eyes become sunken. And ptosis. Meiosis meaning there is constriction of the pupil. Ptosis meaning drooping of the eyelid. And anhidrosis, that means loss of sweating in that area. And finally loss of ciliospinal reflex. And C81 muscles, so it all intrinsic muscles of the hand gets lost, so it forms both median and ulnar clawing. We will discuss about this claw hand in the future slides. So clawing of the hand will occur in Klumpke's paralysis. So How to go about this brachial plexus injuries? Whenever there is any traction injuries, you always wait for 3 weeks. After 3 weeks, you do a nerve conduction study or an electromyographic study. If there are some flicker potential when the study becomes positive, because I don't want to go into details of these studies, these includes lot of parameters to be measured. All these have a significant treatment value. So I'm not going to discuss about those nerve conduction studies or electromyography. If it turns out to be positive sign for recovery, you have to wait for another 3 months. So every 3-month interval you need to do the nerve conduction study, electromyographic study, to uh, detect the progress of the lesion. If it is not showing any signs of recovery, then you have to offer surgery. It is always in case of closed. Whenever there is open and classical transected nerves, we have to go ahead and explore the wound. As I already described about the principles of nerve repair, like good illumination, good exposure, good positioning, bloodless feel, microsurgical sutures, microsurgical instruments, tension free coaptation, lesser number of sutures, all these principles to be followed. Now moving on to treatment option, conservative option, we already discussed how to manage those conservatively, like closed injuries will be managed conservatively, and they have to be checked at frequent intervals and monitored with nerve conduction electromyographic study to monitor the progress of recovery. That is conservative option. Nerve repair, following the principles of nerve repair, we need to follow when the gap is less than 2 cm. Grafting is considered when the gap is more than 2 cm between the two cut end of the nerves. The commonly used grafts we already discussed: sural nerve and medial cutaneous nerve of forearm, and greater auricular nerve, cervical plexus, supraclavicular nerve, etc. Nerve transfer, when the distal nerve trunk is available, whereas the proximal, because of the avulsion from the root, then the proximal is not available. You can use the nearby nerve and directly innervate the paralyzed muscle. So the common nerve transfers we use in brachial plexus will be spinal accessory, that is a cranial nerve 11, spinal accessory nerve to innervate either axillary nerve to supply the deltoid. Number 2, you can use intercostal nerves to innervate median nerve or ulnar nerve. These are examples for nerve transfers. And all these are called primary surgeries. All these are called primary surgical modalities. When the primary surgical treatment fails, you have to go for secondary treatment options. So the secondary treatment options is generally done for injuries, nerve injuries that present late. That means more than 1 year. After 1 year, there is less chance for recovery with the nerve transfer or nerve grafting. So we have to do a tendon transfer, wherein you take a tendon and you transfer it to the paralyzed muscle. So in that way you can achieve the function you needed. We will discuss about this tendon transfer later. Basically tendon transfer, it's a tricky thing. Tendon transfer, like for when the deltoid has been, so for example you take the brachial plexus, deltoid is paralyzed. Okay, this paralyzed muscle is supplied by axillary nerve. This axillary nerve injury, due to brachial plexus, the axillary nerve has also undergone degeneration. The chances of recovery of the axillary nerve, even when nerve transfer has done, it's very likely, since it has been presented very late. In such situation, the functioning tendon of the trapezius muscle can be transferred to the deltoid muscle tendon. Thereby, whenever the trapezius contracts, deltoid also functions. So trapezius tendon transfer to deltoid is an example of a tendon transfer. So whenever trapezius muscle functions, trapezius is supplied by spinal axis nerve. Trapezius functions, deltoid also acquire a function. So although the definitive action, the final action is not going to be as before, it gives some progressive improvement. It will avoid the obvious deformity. So this is the basis of tendon transfer. The strength is very minimal. Now moving on to next nerve injury, that is the median nerve injury. Median nerve injury arises from the brachial plexus, from the lateral as well as medial root of lateral and medial cord. So the root value of median nerve is going to be C5 to T1. So this median nerve supplies all muscles of the forearm. That means flexor compartment of the forearm will be supplied by the median nerve, right? And also the thenar eminence. Thenar is this thing. This is the thenar eminence. So this thenar eminence has abductor pollicis brevis. So all muscles of forearm will be supplied. All muscles of flexor compartment of forearm and thenar muscles. Thenar muscles and the abductor pollicis brevis. Opponents pollicis. Abductor pollicis is used to abduct. Opponents is to do like this, opposition of thumb with the little fingers. And also flexor pollicis brevis, that is flexion of the thumb. And also it supplies the lumbrical muscles, lateral to lumbricals. So these are the muscles that are innervated by median nerve. So whenever the median nerve gets injured, the common causes being number 1, fracture, supracondylar fracture humerus, or a fracture forearm bones, or any surgical cut injury or traumatic cut to the median nerve, or even carpal tunnel syndrome, because median nerve has to enter the hand through the carpal tunnel, that is that is formed by the flexor retinaculum running over the carpal bones. So it is a closed tunnel system wherein any lesion or any edema or any trauma or any fracture will cause compression neuropathy of the median nerve, thereby reflecting the median nerve deformity. The median nerve deformity, or what are the deformities that the median nerve can cause? Number 1. So when the thenar muscles lose their becomes paralyzed, they become atrophied. So no thenar eminence. So the bulge in the thenar aspect. So see, I have the bulge in the thenar aspect. That bulge will be lost in patients with median nerve injury. And this is the pen test. Pen test is nothing but, so this is called abduction of the thumb. So I can go abduct my thumb and touch the pen. So abduction will be lost. So pen test. Then Oshner's clasping test. Since when the median nerve gets injured, the flexor digitorum profundus, that is responsible for this terminal phalanx, and flexor digitorum superficial, that is responsible for flexion at the intercarpal joint, right, interphalangeal joint. So this is not possible for these two fingers. So when you clasp, this is the normal clasp we can do, but in median nerve injury these two fingers cannot be flexed, so it will be like this. So this is called benediction sign or Oshner's clasp test positive. And the final thing is, since so the thenar eminence will be lost, so there is more pull of the adductor pollicis, so it will cause aphthum deformity. So these are the deformity caused by the median nerve injury. Repair treatment as such. So when the carpal tunnel, because of the carpal tunnel syndrome, you just divide the flexor retinaculum. It will release the pressure, thereby releasing the compression. Right. So in a clean cut injury, you do direct nerve repair, or you can use a nerve graft or a nerve transfer. And finally, in end stages, when prolonged injuries where nerve transfer, nerve grafting cannot be done, you can opt for a tendon transfer. There are a lot of tendon transfers available. Based on the patient needs, we can choose what type of tendon transfer can be done. Now moving on to ulnar nerve injury. Ulnar nerve injury has a root value of C8T1. Ulnar nerve usually supplies two muscles in the forearm, flexor carpi ulnaris and median half of flexor digitorum profundus, and all the intrinsic muscles of the hand. So ulnar nerve injury usually occurs surgical trauma or fracture humerus, and the deformity caused due to ulnar nerve. So classical deformity is clawing, claw hand. So why clawing occurs? So generally ulnar nerve is responsible for flexion at the lumbrical flexion at the metacarpophalangeal joint. The lumbricals actions has been lost, along with palmar and dorsal interossei actions also has been lost. So there will be hyperextension at the metacarpophalangeal joint, and there will be flexion at the interphalangeal joint because of the profunda femoris function. So hyperextension at the metacarpophalangeal and flexion at the interphalangeal joint. So this is called clawing. So hyperextension at MCP, flexion at the interphalangeal joint. So this flexion occurs due to action of FDP, flexor digitorum profundus. So this clawing becomes more pronounced in lower ulnar nerve palsy. Like at the level of wrist. When the ulnar nerve gets injured at the level of elbow, the supply to the FDP also will be lost. So the flexion is not more prominent. So the clawing is not more prominent when the lesion is very higher. Generally, whenever a lesion is very higher, the deformity will be more. But whereas in ulnar nerve, when the lesion is very higher, that means at the level of elbow, the flexor digitorum profundus will also get paralyzed. So there won't be flexion at the interphalangeal joint. So the clawing will be less pronounced. Whereas in a lower ulnar nerve lesion, like in the level of wrist, the flexor digitorum profundus is not paralyzed, so there will be more flexion of the interphalangeal joint, thereby causing more clawing. So this concept is called ulnar paradox. The paradox is higher the lesion, lesser the deformity. Higher the lesion, lesser the deformity. The next test to detect the ulnar nerve is book test. Book test. So you place a book or a paper between the fingers and you try to pull it off. So the this test the palmar interossei, that causes abduction. Dorsal interossei causes adduction. I mean Palmar interosseous causes adduction, that is pad. Dorsal interosseous causes abduction, that is dab. Book test is otherwise called as Froment's test or Froment's sign. You place a book between the thumb. You hold it between the thumb. So you can snugly hold the book based on the action of adductor pollicis. This adductor pollicis is supplied by the ulnar nerve. Upon pulling the book, you cannot hold the book if adductor pollicis is not functioning. In such case, you will hold the book by flexing the thumb like this. So this flexion is brought by the abductor pollicis brevis, that is supplied by the median nerve, right? So the Froment's sign positive indicates ulnar nerve injury, and adductor pollicis is paralyzed. So this is what the Froment's sign indicates. The treatment is direct nerve repair, and mostly it requires tendon transfer and nerve grafting, right? This next, the radial nerve injury, the root value is C5 to T1. It is usually caused by crutches. Holding the crutches in the axilla, that causes compression of the nerve, and fracture of the humerus at the spiral groove. All these causes radial nerve injury. Radial nerve injury, commonly the motor phenomenon is wrist drop, and also there is loss of sensation at the dorsal aspect of the lateral two-third, lateral two and of fingers, right? This is the median nerve, radial nerve injury. So treatment, usually it requires tendon transfer, right? Tendon transfer. When it is early or due to surgery, you can go for a nerve repair. Finally, common peroneal nerve injury. Common peroneal nerve is located in the lower limb. So it is a branch of the sciatic nerve. So it usually causes foot drop. Right? So this also usually requires tendon transfer, and mostly people will be using splint and boots by conservatively managing the nerve injuries, right? So these two nerve injuries are quite rare, and that's why I have not explained them in detail. Now moving on to questions. Froment's sign positive indicates, I already described this. Froment's sign positive indicates ulnar nerve injury. It's not median nerve injury. It usually tests the adductor pollicis, not abductor. Brachial plexus injury, that is caused due to forceful hyperabduction. Forceful hyperabduction means lower trunk, that is Klumpke's paralysis. The question is, which is not a feature of Klumpke's paralysis? Horner syndrome is a feature, wasting of the hand is a feature, clawing of the hand is a feature, whereas internally rotated arm is a feature of Erb's paralysis. Which of the following statements regarding peripheral nerve injury is false? Higher the median nerve lesion, more the paralyzed muscle, obviously. Higher the ulnar nerve lesion, more is the clawing. This is not a thing, because ulnar paradox occurs. That means higher the lesion, there is paralysis of flexor digitorum profundus also, so less clawing. Flexion of wrist causes severe pain. Is seen with usually the flexion of wrist. This is flexion of wrist. So this is a test called Phalen's test. When flexion of this wrist causing pain that indicates carpal tunnel syndrome. So carpal tunnel syndrome is a median compression nerve neuropathy. So with this we have completed the peripheral injuries and as well as the specific nerve injuries. Thank you.